So good afternoon, everyone. Good afternoon also to those who are attending, joining us virtually. We're really happy to welcome you to the marketing session. So I hope you all enjoy. First, let me introduce myself. My name is Marie-Claude Lachance, and I'm the marketing manager leading the molecular and immunoassay franchises. So I hope you enjoyed the AMR Symposium yesterday and this morning, and that, like me, you're leaving those discussions both inspired and challenged. We heard powerful insights about the growing threats of antimicrobial resistance, but also about the opportunity we have right now to shape a future where diagnostics, stewardship, and innovation work hand in hand together to protect patients, the system, and our society. This afternoon, we'll take that conversation a step further, and we're going to be shifting for why it matters, what we can do with our technologies. So how do we build stronger partnership between clinical, operational, financial stakeholders? And ultimately, how do we ensure that innovation brings measurable value to patient care? Today's session is designed precisely around those questions. We have 3 presentations, each addressing crucial part of the journey from vision to execution. First, we'll be exploring bridging the gap and advancing antimicrobial stewardship. And then we'll be shifting the conversation also to look more at the practical aspect, where we're going to have Dr. Leung presenting more of a business case that he's worked on at his site. Finally, we'll go back to the laboratory heart of stewardship, where we're going to be discussing antibiograms. So, as we begin, I invite you to keep one thought in mind. AMR is not just a clinical challenge, it's a coordination challenge. And the greatest impact will come from collaboration across roles, institutions, system, and industry like bioMérieux. So without further ado, let me introduce you to Kirsten Jensen, who's part of my team, market manager for molecular, and she will be hosting the next discussion panel. Thank you very much.
Thank you very much. So why am I standing on stage? I am not the smartest person in the room. I have worked, however, for approximately 12 years across Canada in point-of-care implementations. So that is laboratory diagnostics, not in the lab anymore, but at the point of care. And I have seen all manners of things where communication was never quite ideal from the beginning. Sometimes that's by design, sometimes that's just the nature of things. So I was really excited to moderate this session today because it's all wonderful to have a beautiful innovation, but if it doesn't have the ability to affect a change at a systems level, it stays a beautiful innovation. So this talk is about bridging that gap between diagnostics and antimicrobial stewardship. So how do you get everybody to talk the same language, have the same mission and values, even if they come from a completely different area? Now, that gap looks very different depending on your role and your perspective. And I'd like to begin by asking my panelists, what this means in their daily practice. But before I talk about their daily practice, let me introduce them. So I've got Dr. Eddy Lang at the end, and he is an ER physician and researcher who has got extensive experience in what diagnostics kind of looks like from his perspective. He's well published. You probably saw a talk on him that he gave yesterday as well. I've also got Dr. Brad Langford, who is an antimicrobial pharmacist, who also has been on at least one panel, and I think this is your second, maybe more?
Second.
And actually has a paper published with Kasia from our group as well on antimicrobial stewardship. I also have Dr. Purewal, who is a pediatric infectious disease specialist out of Saskatchewan and working really with those populations where they've got, a really different need for diagnostics than someone in downtown Toronto. And you have the Canadian Breakpoint podcast. There was interviews going on this morning. There's a really fantastic episode on sepsis from last year with Dr. Fox Robichar that I really liked. We've also got Dr. Callie Barrett, who's a critical care physician, and really your specialty is in the health, the HTA, that therapeutic assessment, and saying, okay, it's cool, but what does this actually mean for my patients? And then I've also invited Jessica from our group to really provide that, I have a view across Canada, across the US and the world of what's kind of upcoming and where that fits in and where you see some of the gaps occurring and how they could be looking at. So I really wanted to kind of get a really diverse group of stakeholders here because I think it's so important to have a different sort of diagnosis of the problem from different perspectives. So starting with you, Dr. Lang, in your practice or the practice of your colleagues, where do you see a gap, and what sort of challenges do you see that could come up in trying to address that gap?
Thanks for the question, and just want to apologize from the get-go that I do have to step out early. I was always somewhat aware of a gap, but it really became crystallized over the last 24 hours. Preparing my presentation and hearing all the work that's going on here. Where I see the gap, there's obviously the patients who roll through the door who are critically ill and whom we suspect sepsis, and they're pretty diagnostically clear. There's the very, very low acuity. Those are clear. It's that middle group. And I think there's a potential opportunity there to do a lot better with that middle population. It would have to be based on a number of things coming together, including good clinical data, maybe a clinical practice guideline, and just making the business case for why we need advanced diagnostics in that middle group. So I think we can get there. The problem we have, as much as we are integrated in Alberta with a central electronic health record, and that gives us a huge advantage, we're still very siloed. Everybody's got their own budget, and no one cares necessarily all that much about AMR in the same way across the board. So I think once we can establish some good data, demonstrate variability in practice, demonstrate the local harms caused through AMR, that will start creating that burning platform that you need for a quality improvement project.
That's a wonderful answer, and really quality improvement is where it comes. So Dr. Langford, you've worked across both clinical practice and public health. What are some of the common barriers you see when trying to translate that diagnostic data that you might see into stewardship decisions?
Mm-hmm. I think the key piece is bedside clinical decision support, which is integrated into workflow. So once you start having to press extra buttons, or you get pop-up alerts, or there's something that you put up on the wall that you hope people will read, those are not necessarily good causes. But when you make the right decision easy and at your fingertips, and I think with many of the electronic health records, that's a possibility. That is probably the secret sauce to getting stewardship to happen. There's only so far you can get appealing to people's goodwill and desire to reduce a public health problem. But if you put the right answer right in front of them and say, by the way, you really should reconsider antibiotics for this patient because of X, or here's a shared decision-making tool that that I'll print off for you automatically, so that you can engage in a discussion with this patient about not receiving antibiotics. Once those tools are readily available at the point of care and easy to access and not disrupting a busy workflow, that's going to be the secret ingredient.
Absolutely. So moving to Dr. Langford, in your work in antimicrobial stewardship, in your group, what have you seen, what are the gaps you've seen between that diagnostic stewardship and then the antimicrobial stewardship side of things?
Yeah, so thanks for the question. I work both in the public health setting for a province, Public Health Ontario, and I also work in a small, medium-sized rehab hospital. So there's some real bread and butter issues that come up on a regular basis that I see gaps in, one of which is urine culturing and over-culturing of the urine. And I think one of the gaps there is having clinical context at the time of getting your results back. And if you don't have that clinical context, it's very easy to respond inappropriately to that result. And I see that time and time again with, unnecessary cultures leading to unnecessary antibiotic use. So we try to do some things to address that in our facility. We've developed a scoring tool. We called it the bladder score. Each letter in the word bladder counts for a symptom. And it's the low criteria essentially, but made a little bit easier to use. And we found that made a difference. So that's one of the ways we tried to address a common gap that we see.
Right. Dr. Purewal, moving to your experience in pediatric infectious diseases, how do you see diagnostics innovations shaping stewardship in the coming years, especially pediatric care where that important diagnosis might be a life changer for that child?
Yeah, that's also a really good question, and a topic that we had Dr. Pernica actually talk a little bit about, the role of rapid diagnostics. And so in pediatrics, I think one of the challenging things is the type of presentations can be very nonspecific. So fever, lethargy, poor feeding, irritability are probably vast majority of those infants that are presenting, for instance, and it's very nonspecific. So I do think that there is role for rapid diagnostics. We kind of talked a little bit about having these biomarkers and helping with creating that. We definitely see it with rapid viral testing already in terms of having, like, during RSV, COVID, flu season, the rapid test comes back. There's probably less use of antibiotics in that population. So I think that's a key thing, especially in emergency departments. And then in my world, I also do a lot of congenital infections. And so for me, having rapid tests or point of care tests with syphilis or HIV is very helpful. And this is usually done on the birthing parent, where then I can assess kind of that risk of transmission. So I definitely think that there's room for rapid diagnostics and to bridge that gap. And to help with stewardship, for sure. I do think it's an evolving picture. It's definitely a challenging picture, and what we heard from Dr. Pernica's talk as well is that we have to look at the whole picture. So it's not just one, I think, aspect of, a test comes back positive for the rapid test, and then we have our answer. It's probably not the right thing.
Yeah. No, and definitely now moving to another area of the hospital where you have some of the sickest patients that end up. Dr. Barrett, in your settings where time and resources can be quite constrained and quite valuable when they are available, have you seen any systemic barriers that, affect how diagnostic results might be acted upon?
Yeah, so, in my clinical environment as a critical care physician, if I'm showing up, you're having a really bad day. So for us, we have to consider both antimicrobial resistance and stewardship, and the fact that if you need antibiotics, we think you have sepsis, and so you need to get antibiotics as quickly as possible. And so our decision making is choosing the best empiric antibiotic that we can that will cover what we suspect could be one of the bacteria at play. And then for us, we have to think of a few things. We have to think of, is this person colonized already with a bacteria that is multi-drug resistant? And I'll say that majority of my patients in one of the places I work are already colonized with multi-drug resistant Pseudomonas and Klebsiella. And so a positive, someone getting sick, I'm now thinking I have to cover those resistant organisms. But then also thinking, getting the results back. And so it's time to results is a huge problem for us. The swabs are taken or the samples are taken and then they're sent to a lab, maybe at another institution. We heard earlier that it's sometimes across the city. So then that plate gets cultured, and now we're waiting for it to either pop up in an EMR if you're in the same system, or a fax to come, or in Ontario we don't have the luxury what you do in Alberta, go on to this very archaic system called Connecting Ontario, and hope that lab result is up there. So the communication between the lab and the clinicians are so slow. That we're talking days. And so that is 3-4 days of potentially inappropriate broad spectrum antibiotics that's likely contributing to resistance. But I have to, because the alternative is this patient is going to die from sepsis. So for us, I think tools that would enable us to make more accurate decisions in terms of what's the bug and what drug's going to work would be incredibly helpful for us in terms of being able to reduce our burden and the way we contribute to antimicrobial resistance.
I fully agree. You know, I have seen every manner of IT systems across Canada, having worked in all of them. And sometimes there is that immediacy of result and you get a pop-up and you get an email. Sometimes you get a phone call, and sometimes it doesn't. You get stuck in an LAS somewhere. So I have seen all sorts of things. Dr. Blavignac, with your broad perspective across diagnostics and across healthcare systems, like you have literally read studies from across the world and have seen the best practices and the not so best practices. And looking at that continuum of care, what do you think would most transform how stewardship decisions are integrated in the next few years? Do you see anything on the horizon that you're excited about?
So I guess I have to say that the willingness of the people who are already in this ecosystem it is not something to undermine. There's people who are very much willing to make a lot of changes, to put a lot of practice in place. I think where the biggest issues lie is within the efforts and the funding and the policies. There's a lot of different environments, different institutions, whether we compare even tertiary centers amongst one another, that don't have the same way of reporting, the same way of putting emphasis on some of the diagnostic tests that could make a difference in antimicrobial stewardship, or even patient care for that matter. There are some inequities that I think we can't shy away from. And this is across the world. And when we look at a country like Canada, which is a G7 country, it's almost very unfortunate to see that in some large cities, we have some even discrepancies across the different centers that are within the GTA, within the Vancouver area, within the Montreal area. And then when we consider rural and community areas, it's even worse. So I think there is a role for government to play to be able to allow for better access across different geographies and populations.
Absolutely. And I think that's really important to kind of recognize is that, that inequity side of things, the reality of the way the Canada Health Act is written is you must provide care. It often does not decide what that care or a metric could look like for that care. It's here's some money, you must provide care. So switching to kind of the, going really more into this theme of like communication barriers and things, one of the things I have always had a conversation on a lab side is, okay, so let's get this result. We can get it within 45 minutes. How fast can you actually get it to the clinician in a time frame that they can then act on that? So this question is for the panel. If diagnostics are fast and accurate, have you ever seen that there's been a result that wasn't always translated into a timely action? And do you see in retrospect that there might be a practical step or action that could help bridge that gap?
All right, I can speak. So depending on your EMR system or the institution you're working at, you may not know that a culture is positive until you go into the individual's chart and look at the results for microbiology. So you may not be getting a flag. And then there are other ways to communicate with the physician responsible for that individual. And so I think I've worked in institutions where you got a phone call when a culture was positive. You got a phone call when the sensitivities were back, and that was very, very helpful and useful and timely. I'm sure very resource intensive on the other end. It increased the communication and my understanding of who those people were, which was also very helpful because otherwise it's just a computer generated result. But when there's no flag or warning and you don't know when the result's back, you're not always checking your inbox when you're rounding in a hospital, it could be hours. So it really just depends on the workflow.
If I may add to this, I think this is, you asked me what I'm most excited about in the previous question, which I didn't address, but I think it speaks to that. There are softwares, there are tools that exist that I think are not prioritized in the healthcare systems that do flag essentially or can even assist in clinical decision making in settings where there is nobody that has the competencies and skills to be able to interpret the data. So when we talk about rural communities where there's no microbiologists, there are tools that do exist, and in terms of connectivity as well. I think we now live in a world in 2025 where there is an opportunity to connect large tertiary centers that have the expertise to be able to oversee some of the results and guide clinicians at the other end who are in the community setting and don't have the same resources to be able to provide the appropriate care. But then it goes back to how do we enable not only from sharing the data, sharing the information, but also allow the funding for those systems to be put in place.
Yeah, I think it's a timely question because a lot of hospitals are either upgrading their electronic health records or they're implementing a new electronic health record with computerized provider order entry. And there's so many opportunities there to leverage that. But I think the challenge is there's a lot of competing priorities when that's being implemented. They're trying to do it really quickly. Stewardship is just one voice. And so sometimes that gets overlooked. And so I worry that it's a bit of a missed opportunity often, what could be done versus what's actually being done with the EHR. I will say that sometimes for my practice, it's not always like timely reaction to results. Sometimes it's more overreaction, and we want to prevent that overreaction. I wanted to shout out to Dr. Larissa Matuka. Some of the work that we're doing is with nudging. As the microbiology report comes back to the clinician, that's a communication method in which we can help to guide prescribing a little bit better through selective reporting, only showing the antibiotics we think that are more reasonable, using framing and nudging comments to maybe give some context about potential colonizers, for example. And so we're doing some work right now to look at an updated systematic review. We're doing a vignette trial and hopefully a prospective trial too in the future to look at how we can nudge people to better prescribing decisions through the microbiology reports.
I could add maybe a little bit more, which I think is really a fantastic work that you're doing when it comes to also diagnostic stewardship. So one of the things that keep coming back, and I mentioned funding, is that we often see over requesting of tests, and that also leads to more antibiotics consumption in some areas. So I think there is merit to your point in being able to nudge, but maybe with some caution and guidance around that.
And, I think what I really love hearing about what you were saying about the nudges is that not everyone can be an expert on all things at all times. And I think especially for those physicians who might not see it that often or, that might address some of their questions at the time they have them as well. I'd be curious, do you get to send those papers back to the policymakers to say, hey, this is some actual research. Can I get some funding to modify my microbiology report and some IT budget to do that side of things?
Yeah, I think that would be a next step. We're not quite at that stage yet, but we're gathering lots of data. In the last 5 years or so, it's ballooned the number of literature and research studies on this topic. So there's clearly an interest in it. But yeah, funding is kind of scarce, but that would be a next step. We're actually looking for funding for our prospective studies, so we're hoping that that's next for us.
Wonderful. Yeah, no, and thank you for, people coming and talking about this, because I think it's a good conversation to be had. And really the focus today is just to kind of, identify these and see what could be good ideas to take back. So going about, the next theme, so diagnostics as enablers. So starting with you, Dr. Langford, what diagnostic tools have had the greatest impact in stewardship in your institution? We were talking a little bit about antibiograms, for example.
Mm-hmm. Yeah, there's one that I wanted to talk about that's not in my institution, but I would really like it to be. And I know antibiograms, they can be great, but there's some challenges with them. One, we found that in Ontario, they're quite different from each other in terms of how laboratories prepare them. There's a lot of inconsistencies between the populations that are included, how they stratify them. And then even if you have a really good antibiogram, it doesn't really tell you for that specific patient what empiric therapy you should be using. It's not that great of a predictor of what bug they're going to get. So I think this goes back to the piece about, clinical context, what information about the patient can you glean as well in the context of the antibiogram. And so there's some really cool trials. The INSPIRE randomized controlled trials Dr. Shruti Gohil has led about 4 of them already, and they're cluster RCTs. And they basically looked at CPOE, computerized provider order entry prompts at the time of prescribing using a predictive algorithm that takes into account your local susceptibility data, as well as that patient's history, maybe prior culture results, prior clinical information, and gives you a percentage risk of MDROs at the time of prescribing. If it's a low risk of MDROs, it'll flag you to say, hey, maybe you don't need that piptazo, and you can use broader or narrower spectrum therapy. And they found in all of their RCTs a reduction in broad spectrum antibiotic days of therapy as a result of that. So like that's, I think, super cool, and I would like to be able to implement that, but there's a lot of steps that are required for integration and resources, working with IT, et cetera.
You know, Dr. Barrett or Dr. Purewal, you know, if you had access to like the biggest innovation tomorrow, let's say, that would allow you to say definitively this patient has X versus Y, do you see how you could potentially incorporate that into your workflow, or do you think there would still be a whole lot of work that would need to be done to say, yes, this is something I could do? So let's say, for example, there is some additional work being happening with syphilis at a molecular level, because a lot of times syphilis is a serology test. So where do you see sort of diagnostics as enablers in your practice, I guess?
Yeah, I think there's definitely room for those types of diagnostic enablers. I mean, I talk about syphilis because it's a problem, and it's a huge problem in our province. So, I mean, there's role there for sure. I think there are some kind of rapid tests, like we talked about, point of care tests that have been instituted. But again, they're not helpful because, again, they're more serological based as well, right? So if somebody's had a previous infection, probably doesn't give you a lot of information. I think there's definitely area for it. I think one of where I really would want to focus is kind of community stewardship, because I think in pediatrics, as many of us know, that and in adults, but in pediatrics as well, majority of antibiotics are prescribed in the community. And I think the infrastructure has to be very different. So it's not a one answer response for every community clinic, acute care clinic, smaller hospital in the community, that type of thing, who can't admit patients. So I think the framework is very different, and you have to, what I would love is to have a certain area and figure out what their needs are in terms of, is it STI testing that needs to be done more rapidly? It depends on the patient population that they're seeing. And then I think education and awareness around that is also the key. So I would probably shift my gear to more putting in my money into community stewardship, because I feel like that's where it would be magical to wake up and have an option, right? Because there's so many times we get phone calls from the periphery, and you know, they're in the middle of nowhere and they don't have the testing abilities or that turnaround time that we talked about, right? So we, at least working at an academic center, have a lab that's there. The turnaround time for some of these places is very long, and I'm like on the phone calling for cultures. Where did the specimen go? It got lost in the cab. Okay, I have no idea why it was even in the cab to begin with. You know, and so for sure, I think there's a lot of role for implementation of newer technologies and newer things in the community.
Right. And Dr. Barrett, like in your critical care area, you know, you're dealing with some of the sickest patients to begin with. They might have multiple other diseases that they've been diagnosed with, whether it be autoimmune disorders or whatnot along the way. Where do you see diagnostics as enablers, maybe in ventilated patients, for example, on the microbiology side? What do you see that you could look into your practice and say that makes sense or that doesn't make sense?
I think point of care pathogen identification and sensitivity testing would be a game changer. So, for instance, I've worked in an ICU where the piptazo resistance of Pseudomonas was 50%. So if someone develops a VAP, I have a 1 in 2 chance that if I use empiric piptazo, it's not going to work. So I give Miro. So I would love in that instance to be able to know, is this drug sensitive to piptazo? Can I even narrow more? So that would be a huge game changer, I think. And even just rapid gram-negative, gram-positive might be a game changer. I don't know if that exists, but it certainly might help me a little bit. So I think for these critically ill patients where a ventilator-associated pneumonia is almost always bacterial. So in those cases, right, like it's almost always bacterial. It's rarely viral. And so I'm giving antibiotics. And so to be able to narrow my choice right up front, that would be very helpful. I mean, another area that I think this could be helpful is in transplant. So when we think about lung transplant, the lung transplant patients get empiric antibiotics for the first 5 days after the transplant until the donor cultures from the hospital where the donor was come back. And so you then sometimes have 5 to 7 days of unnecessary exposure to broad spectrum antibiotics in that population. And that is an immune compromised now, like very immune compromised patient who you're dealing with 2 potential hosts. So that's another area where I think rapid testing would truly be a game changer in terms of AMR.
So, coming back to those lung transplant patients, they're going back out in the hospital. So thinking about the long-term care settings, the rehab settings, the outpatient settings, most patients, if they're doing okay, are going to eventually be out in the community. So how does antimicrobial stewardship programs look like that in those communities? Starting with you, Dr. Langford, what does that look like once they're out and about, so to speak? Mm-hmm.
Yeah, there's some work that we're trying to do outside of the hospital setting. Long-term care is one example where we are working on trying to provide long-term care homes with their own antibiograms to help support their empiric prescribing. We know that there's 630 LTCs in Ontario, so there's many of them, and none of them really have the capability to produce their own antibiogram or the expertise to do that work. So we've got a grant to develop 630 individualized antibiograms for those long-term care homes. And Nick Daneman is our PI for that project, and we're hoping to send those out in the new year. But knowing that, taking into account some of those nudge principles, we don't want to just give them the antibiogram. You want to think about the choice architecture, which first-line agents are you suggesting? Did you even need a culture in the first place? So I think this may be an opportunity for public health to support some of the work that's happening outside of hospitals where they don't really have the resources to do this these kind of antibiograms.
And Dr. Purewal, the best case scenario is you have a child who's quite sick and then gets sent back with parents and is doing much better, so back out in the community. How does antimicrobial stewardship look like in your practice?
Yeah, so I do a lot of inpatient work, but we do like community or like clinics, outpatient. And the majority of the interaction I have with the community would be if I'm on call and I have an outside call from a community physician. So I think there are challenges for sure in terms of choosing the right empiric antibiotics or even like step down of antibiotics, duration of antibiotics, and there's not a whole lot of guidelines. So I think most people who practice infectious disease or people or anybody that's around us, we usually give 5 to 7 days, give 7 to 10 days, right? But we have these durations or ranges of durations that have come out. And so I think one of the biggest challenges is there because you're trying to, incorporate guidelines, consensus, maybe biomarkers that could be helpful in those areas. But again, I think it's the accessibility, right? So I don't know if every community or outpatient area has somebody that they can pick up the phone and call, like telehealth or phone advice for ID consultation. I know that there are some institutions that and provinces that have implemented really good EMR systems that have inpatient, outpatient EMR. So you can actually see kind of the notes. And I trained in the US where I had a similar EMR, and it was really nice to know that out in the community now the antibiotics have been stopped, and this was a patient I saw inpatient, right? So again, going back to the key communication between physicians also is important. And that's what sometimes it's difficult. You can't follow those patients because you can't follow every single patient. And a lot of them do see primary care. One of the things in Saskatchewan, which I always found kind of fascinating, I grew up in Alberta, so I had a pediatrician growing up. In Saskatchewan, if you don't have a complex medical condition as a child, you actually are seen by a family doctor. And so I think the training and the education to make sure that they feel secure enough to make these clinical decisions and diagnoses is really important. And I do a lot of work with the undergraduate medical education, and actually in the family residency program, they don't have a pediatric specific rotation. And I find that fascinating that there's that barrier there, because now you're expected to, maybe you saw a few pediatric patients in medical school, but now in your residency training, you're not really seeing a vast majority unless you're doing some community care practice, but you're not rotating through pediatrics. And I think that is also something where we have to work on in terms of education and training, because I can't imagine how uncomfortable somebody would feel if you've never had training in that area. And so I think there's a lot of, I guess, areas that need work in, but I think there are like digital tools that are helping. I had a discussion with the Public Health Agency of Canada today. They came out with their Canadian treatment guides, guidance for antibiotics, which I think is going to be a great resourceful tool. So there's definitely resources out there. I think just education around where to find those resources is really important.
Yeah, that's actually a very good point, is exactly these are the resources available to me. This one is, at a Canadian-wide level. This one might be my provincial level. And, how do I determine if there's a discrepancy, which one I should be following, and knowing who you can call.
Yes.
Now, Dr. Barrett, you're often the expert in someone in your facility that's quite sick, and I think your main goal would be to see them eventually get discharged. How do you ever get phone calls from outside going, hey, I have this patient that was yours? Or do you ever, when do you get to see the whole journey of that patient? What does that look like? Is there a communication back of like, hey, they're doing well, they're in?
The average critical care physician does not. No. I do have this privilege of actually working in a clinic with Dr. Margaret Herridge, who has a CIHR-funded study where she's been following people who had COVID-19. And so they weren't necessarily my patients, but I've examined some of her patients in the clinic through her study. But yeah, no, I get almost no feedback unless someone's done really well, and then they'll come by, and if they were in the ICU for a long time, they'll sometimes, back in the hospital for an appointment, they'll come by to see the staff and say hi. But that's very rare.
The reason why I bring that up is because, what you're doing there can truly save someone's life. And I'm curious to see, especially from the antimicrobial stewardship side of things, like, do you ever get somebody going, oh yeah, that antibiotic was just terrible?
No, it's the other stuff we do. Yeah.
So I want to spend a little bit of time on the last theme, and that's the measuring the impact. So I think we can have a conversation all day long, but most places in the world, they say, great, you want to do this amazing new thing. You want to get something that's purple that can tell somebody that, X, Y, or Z. How much is it going to cost, and how do I know it's going to work? So I really want to hear from each of the stakeholders here, starting with Jessica, of what sort of key performance indicators, and I love this term, key performance indicators. It is such a business term, KPIs, but it's something that has become just part of the world. How do you explain to somebody you need money from, other than, hey, I have a KPI, this is what I'm going to be measuring, and this is what I expect the outcomes to roughly be. I want to hear from, starting with Jessica, what sort of key performance indicators should institutes prioritize to measure the success of diagnostic-driven antimicrobial stewardship? I'm curious to see what sort of things you've seen.
So what I've seen, I think, is pretty common in a lot of places, we always look at turnaround time, always like time to optimal results, or length of stay, which keeps coming back. And that's usually also quantified or correlated with the expense at the lab level. I think with antimicrobial stewardship and diagnostics, we need to also look at the medical outcomes and how we're able to produce efficiencies or even savings in other parts of the hospital than just the lab. To me, it has to be a holistic approach. My training is clinical, it's not necessarily microbiology, but looking at the bigger picture, it's not just the cost to the lab, but above and beyond the lab. I think there are some efficiencies that can be gained with rapid diagnostics, where patient outcomes, hospital flow, decongestion of ERs, that could be measured and that could show an impact. Or even if we look at more complex patients, the longitudinal impact of discharging patients early and getting them appropriate care. You're minimizing cost on rehab, you're minimizing cost on occupational health. So I think there's things to consider that go above, and they're more complex to measure, very frankly. Yeah. But I think that the hospital needs to look at things, the administration of the hospital needs to look at above and beyond the traditional metrics, if I may.
I think it's a really important point. And when I think as a clinician under that hat, I'll say I think clinicians are probably rarely consulted when it comes to procurement decisions at the hospital, unless you're a surgeon and there's a specific device you like. So like the lab would never ask me, would you like me to get this reagent test for that bacteria or this one? Like, because I don't have the lab sort of expertise. But I think in rapid diagnostics, it's actually an area where clinicians' preference and workflow will be changed dramatically, and getting the input and perhaps advocacy from clinicians who find that it rapidly, dramatically changes their practice and how they can treat people. I think that's one thing that maybe hasn't been optimized yet. Until I started coming to these conferences and working with you guys, like I didn't know this technology was even out there. And some of the basic science stuff that's been presented here at this conference, like we rarely see that at critical care conferences. So I don't even know that this type of work is in the pipeline from an R&D perspective. So we're just sort of blind to what's going on outside of what's available to us and what our lab is using. When I think from a health economist perspective, and as someone that sits on OTAC and we make funding recommendations, I think this is a problem of evidence and the way evidence is being generated and the type of evidence. And a clinical trial that demonstrates that time to antibiotics or these KPIs that you were mentioning, like time to appropriateness, or those are great metrics, but those are not the metrics that are going to convince a hospital CEO that they need to give the microbiology lab more money. And I do agree that I think this is why having the clinician input as well, because this is now crossing multiple sectors of the clinical practice, and having the potential benefit and cost savings from those different areas of the hospital included in those analyses is very important. There is a societal impact. You would never be able to measure that properly, but you could mention it. So I think like the business case needs to be a little bit more holistic than simply time to appropriate antibiotics. And really no one is producing that kind of evidence right now. It's very clinical, which is great for clinical sort of effectiveness, but in terms of implementation, the data is not there to facilitate implementation and procurement.
Yeah, and you've identified a very interesting gap there. Exactly. I remember many years ago, I had met a CFO and we were chatting about things, and he's like, well, why am I giving money? That is a wonderful question. There are many ways to answer that. And it really, what are you measuring? How are you measuring it? And are you translating your measurement in a way to the people that are going to be speaking to that they understand? So when you have your clinical hat on, you can be like, yeah, that makes sense to me. But when you have your health economist hat, you have to go, does that make sense for the system as a whole?
Yeah.
And I think health technology assessment is something, like when I was in British Columbia, I had met the committee that was doing it when I was in the ministry. It was very interesting because I was trying to get a health technology assessment done for a different point of care device, and I think the assessment took 2 years to produce. And by that time, we had no need for the actual device.
Yeah.
So the difficulty is where could maybe industry bridge that gap, or other groups help to bridge that gap?
One of the things I was even thinking, Fatima, you and I should talk, is when we're developing the Sepsis National Action Plan. I mean, one of the things the Global Sepsis Alliance in their 2030 agenda talks about is prioritizing innovation in diagnostics and treatment. And so maybe there needs to be a research collaborative across the country that is helping to pool the evidence together and, you know, maybe generate a base model that a different device could then be plugged into. Like, maybe we can help as a clinical and academic community help sort of create that evidence. It takes a long time, and they're very, very resource intensive for a very, like a high fidelity, good quality decision model. It takes time. They're a lot of work. And so building one that then could be used for different devices, maybe that might be a sort of a cost-effective way to do the analyses.
Yeah, no, those are some amazing points. Now, Dr. Purewal, in your work in Saskatchewan, I understand you do have that clinical institution. You know, if you were to talk to, you know, let's say the chief financial officer of, you know, a foundation, what sort of things would you kind of bring up as those sort of key performance indicators that are so important to you as a physician and that you can see would have tangible effect?
Yeah, so I guess similar to what Dr. Barrett's saying, I mean, like what I would think would probably be a little bit different from when somebody's making the budget for the year. I think when we're looking at it, I mean, definitely measuring like antibiotic use, time to discharge, costs in terms of hospital costs for IV antibiotics versus oral. I think those are really important measures as well. But then really having kind of that economic standpoint is really important, because in order to make a case for, let's say, a rapid diagnostic test that's going to make things better in terms of funding, like reduce costs for the hospital, I think it's going to be, or for the entire province, is really important. And so I think you have to kind of talk about money and funding and where that can be distributed. I always talk about syphilis, I know, but it's just always on my mind because that's what we do in Saskatchewan. And I'm on the task force, and this has kind of been brought up multiple times, and just give you like a real life example of where there are clinicians involved in some of this decision making. So it's kind of nice that we were invited to have some of these discussions, because I think that is really important. When you're seeing stillbirths, you're seeing hydrops fetalis, you're seeing these very devastating congenital infections that can be prevented. It's quite alarming, and you almost feel helpless, you know, because as a physician, you're always there to want to help the patient, and now I can't help them because that should have been done at the prevention stage, and I should never have been involved, right? So during this task force, we're you know, having these discussions, and everybody's talking about the surveillance aspect, which I think is very important, so like measuring kind of how much disease you have within the community, whether it's looking at the different types of pathogens and priority pathogens that we talk about with AMR as well. So that's definitely there, and you have to look at your numbers. I think looking at the incidence, the prevalence, and all of that is really important, but then kind of having the other lens is what we're doing cost effective right now. And that's where I struggle, because, for instance, when I'm managing these patients and now they've had a high risk of transmission to them, then they require a daily antibiotic for multiple doses, and then are going to be there for a 10-day admission. And a lot of them end up in the ICU, so they're in the NICU. And so you probably know what a daily cost of an ICU bed would be for the hospital.
5 to 10K.
Exactly. Whereas the prevention aspect in this is testing and treating, and the testing and treating and the treatment portion, like if you're non-pregnant, that would be easier. And so it's one dose, probably around like $20 to $50 for the bicillin, and funded. so probably even less in pennies. And then if you're pregnant or the person, birthing parent is pregnant, then they would have maybe multiple courses, but again, not in the 5 to 10K range. So bringing that up and having that kind of discussion, and we've had multiple discussions, I think, in terms of those are the measurements that have been probably more, I guess, getting the ball rolling for us in the province to get more resources and have more of that focus on the prevention. So definitely, like from my standpoint, I think there's a lot of different measurements that are very impactful. I think our stewardship programs do a lot of that too. But when you look at other conditions, I think even in general, even with antibiotics, is looking at costs.
What I find is not being done in microbiology, sorry, but that I've seen in other therapeutic areas, which I find fascinating and could make a point, is looking at the cost of inaction. We keep looking at the cost efficiencies, which I think are hard to showcase in antimicrobial stewardship. But when you look at the cost of not acting, the cost loss of life, the loss of just services, or the cost of having to put in place IPAC measures and not changing the course of action, what does that represent? And that also has inevitably a burden on the health system, at least from my perspective.
Absolutely. And I think it's a little bit counterintuitive to how we sometimes think, that cost of inaction. Dr. Langford, ending with you, measuring impact in your setting or in antimicrobial stewardship, if you were to explain it to a CFO and say, these are the things that I think we should be measuring, what sort of things would be the highest on your priority?
Yeah, I guess because I work at a public health agency for the provincial level, I'm thinking about it from a population perspective, like what's the potential biggest bang for the buck and the biggest potential impact on the population. So the angles may be slightly different, but I do have a bit of an obsession with overculturing of the urine, so I'm going to mention that again. Like obviously we track antimicrobial use, we track antimicrobial resistance, those are very important. Sometimes hard to explain what the, from a financial perspective, what those impacts are. But one thing that we've looked at a lot is urine culturing variability, and we looked at this at the long-term care home level, and it's extremely highly variable between homes. And even if you adjust for patient population, it doesn't explain the variability. And so it's more a prescriber habit, a local culture thing. And what you see is with more urine culturing, you start this cascade. So obviously they're older adults, many of them are asymptomatic, they end up getting antibiotics. When that happens, they end up getting C. diff. So with doubling the rates of urine culturing increases the rate of antibiotic use by 20%, increases the rate of C. diff by 20%. And there's obviously a cost associated with that. And because there's, like hundreds of thousands of them annually, I think it's something that you could potentially target, maybe from a feedback perspective, in addition to the other metrics that we're tracking, and it might have some potential financial benefits too.
So just to kind of really come back to sort of our last takeaways from this. So expanding on what you're talking about, Dr. Langford, what is one change, if you could make it tomorrow, or you could help make, that would kind of bridge this gap and that you would like to see be brought forward from today?
Yeah, one thing we didn't really touch upon too much yet is, from a rapid diagnostics perspective, from a newer testing perspective, there's a lot of interest in sometimes these new shiny objects, making them available for people. But sometimes the challenge is just simply making them available doesn't necessarily result in the action that we want it to happen. And sometimes it can be reverse of what we expect, potential overuse. And so we know this from there's good RCTs, systematic reviews of rapid diagnostics with and without antimicrobial stewardship. And the stewardship is kind of the secret sauce to make that actually work. You need the interpretation, timely interpretation to help support, rapid de-escalation or targeting. So I think that's kind of a key point that we should take going forward, is if we're doing anything that's kind of novel, we need to pair that with stewardship. Same thing goes with biomarkers as well. I think the interest in procalcitonin has kind of waned in the last few years, but and partially because it sometimes doesn't make any difference in prescribing practices. But we tried it in my hospital, in an acute care center, one of the few hospitals that uses it in the ICU to de-escalate or shorten the duration of antibiotic therapy. And we saw when we paired it with stewardship, twice weekly rounds with stewardship, that it was associated with a reduction in usage. We only limit it to the ICU, and there was a benefit, but it's not something that you could just order willy-nilly like in the emerge or on the wards. So I think that's kind of like a key takeaway for me.
Wonderful. Dr. Purewal, what's one change that you would like to see or help make that would kind of bridge that gap that you have seen?
Yeah, I guess I would still probably work on the community stewardship efforts. I think, I don't know, I've been, like, even through my training and then also working for 6 or 7 years now as a staff, I still see, I'm in my own hospital, I don't really have full-fledged pediatric stewardship yet, inpatient, so I think there's a lot of work to branch out of that and go into the community, but I feel like there's actually maybe a bit more need in the community right now, or there always probably has been, but that's what I'm seeing at this moment. And the reason being is that the lack of resources, I feel like inpatient, we have ID pharmacists, we have our ASP pharmacists that are rounding with us. We have, a larger team. You're able to see the patient daily, make those decisions. You can order a procalcitonin, that type of thing. I do think that there's some good data with the ICU that came out of a Dutch group in terms of the SAPS trial that I'm trying to implement now and extrapolate and bring into the pediatric world as well about discontinuation of antibiotics. Because again, like we talked about, this 7 to 10 days or 5 to 7 days is really not going to cut it anymore in terms of the drive towards like reducing AMR, right? So yeah, I think that's probably one of the things I'd like to implement. I guess the last thing I want to touch on is in terms of, I know there's a bunch of trainees out there in our audience today, a lot that listen to our podcast as well. And I really think it's super important if you're in the world, like if you're ever going to prescribe an antibiotic, or send a diagnostic test, which I think most of us probably at some point would. It's really important to have these discussions with your microbiologist and have that communication, because I come from a smaller center, so I think I have the luxury of texting my microbiologist. Probably they're not super happy about that, but I do have that luxury, and I can ask, what is the sensitivity and specificity of this assay? How fast am I going to get this? Like, what's the turnaround time on this, right? But I'm lucky that I was able to kind of build those relationships. And so I think for like early career physicians, and even if you're just interested, I think microbiologists love to tell you what tests they have, and they want to talk about their instrumentation. I think it's really important for us. If you're ordering a test, I think we should know the pathway to what happens with that test, because there's a lot of information. And to be honest, it could be as simple as a urine culture. So you go back to your favorite topic about urine cultures, and that is also the bane of my existence, because I see all these low colony E. faecalis, right, calls like all the time, and interpretation of a urinalysis, and there's obviously implementation of like reflux cascades and these types of things that have been put into stewardship programs where if you have a normal UA, you won't get a urine culture. But I think despite that, in pediatrics, some things get slid through just because of the vulnerable patient population, and then they do report these out. And so we've had to work really closely with our microbiologists to do that. And so really have a good relationship with your microbiologist is what I would say is my take-home message.
Absolutely, that is so key, being able to speak between those silos that could exist in the hospital and sometimes do. Dr. Barrett, putting on, your takeaways today, what's the one change you'd like to see or help make in your areas to bridge that gap?
I think we need better evidence to build a better business case in the places where we know it works.
I love that. And Jessica, what's one thing that you think you could, bring up that you've seen has helped start to bridge this gap in places that you've been talking with around the gap between diagnostics and antimicrobial stewardship?
Connectivity. Just getting people connected, communication of information across borders, across institutions.
Wonderful. I also agree with that one. Again, these people are way smarter than I am. And with that, I'd like to say thank you all for your attendance. I hope that some of the conversations we had today spark some ideas of what you'd like to think about, and maybe you can chat with some of the panelists after to see if they have any more questions. Thank you all for your time. I really appreciate it.